I didn't actually hear any of that.
Oh, I was like, do you want to make a start? People will join. I'm sure people will join in a bit.
Yeah. Okay. Okay. So, what is? Okay. So this is going to be just like a bit of everything. I tried to make it as like broad as I possibly could. So we're just going to go straight into it. So the first question is this one. There's no mentee today. We're going to give Anush a break. So just note it down on a piece of paper. Anush, it says that I've just got a message from Precious that she's struggling to get onto the Teams. Can you hear me?
I think it's gotten somewhere.
Oh, okay, that's fine. We'll just carry on. I think it's okay. So yeah, okay. Have you guys noted down your answers?
Just give me 1 sec. Just to read it.
Fine. Cool. Okay. Anyone want to suggest their answer?
I've got no clue, to be honest.
Yeah, I mean, the
Okay,
only thing I can really do is rule out things, I think.
Okay, do that. Go for it.
So I've never heard of smoking causing a seizure, so I very much doubt that. He doesn't seem to have any signs of meningitis.
Yeah.
No, like recent infection or anything which would suggest that he had an infection at the time that he started seizing. She's adamant that he doesn't use recreational drugs, so I'm not sure. There doesn't seem to be any other evidence for it. It could be an option if she doesn't know. And then it doesn't sound like he's drinking a lot, so I guess uncontrolled epilepsy would be my number one by ruling things out.
Okay.
Because though his last seizure was over 5 years ago, doesn't mean he can't have another seizure. That's impossible.
Yeah.
So
Okay. Okay. So, the answer was actually smoking. And I'm really glad that you like ruled the others out the way you did, because that was the same justification I would have. And at the beginning, when you were like, well, I've never heard of smoking, that's really good, because then it just means that this is something that you're just going to learn now. So smoking doesn't cause seizures, you're right. But in someone who has a medication dependent on the P450 system, it will make it induces the system, so it will make it less effective, the drug. So it means that their carbamazepine won't work as well, and that's why he's having the seizure. If you have an inhibitor of the P450 system, it will mean they don't metabolize the drug as quickly, and that causes toxicity. But the key difference here is, like, with the inducers, you've got to be taking it for some time. With the inhibitors, it needs a more immediate effect. And I would say that, like, roughly learn them from past med. Don't bother with the really niched drugs, but learn the sort of like common stuff. And always have that in the back of your mind. So if you're like, none of the options fit what's going on to this person and they are on any medication, think like, is their medication working? And yeah, if I put the like recreational drug use and the uncontrolled epilepsy in there, because like there's no reason in most histories to not trust what the patient tells you. So like if they've told you they're taking their medication and they haven't had a seizure for years, and they told you they don't take drugs, they probably don't. Okay, so case 1 continued. The MedReg has asked you to prescribe his initial management for his seizure. So everyone get your drug charts out and prescribe what you would for Tom. You have IV access. Okay. Do you guys want more time, less time?
I'm still on patient details.
Okay, yeah, I'll give you another 2 minutes.
Wait, is he still seizing? As in,
Yes, yeah, he's still seizing.
cool, thanks.
Okay, so I'm going to give you 1 more minute. Okay, so let's go over it. Does anyone want to share what they've prescribed?
IV lorazepam.
Yeah, cool. And which section of the drug chart have you put it in?
I guessed it, and I put it on the once only prescription.
Yeah, that was right. So you would have done the lorazepam 4 milligrams, which is what the BNF says if you checked, or if you knew it, IV, and then you would have signed it. Does anyone know why you wouldn't have put it in the infusions bit?
Is it like an injection directly?
Yeah, exactly. So you literally just get the like vial of lorazepam, draw it up, and put it through his cannula. You don't have to like infuse it in a fluid, so you don't have to put a rate on it basically, which is why it can go in your once only prescriptions. Okay, cool. So we're just going to do a quick recap of status. So if this is an OSCE station or real life, it's always an A to E. And you don't forget to call for help really early on. Who's the like main person that you want help from? What kind of medical professional?
Anaesthetist.
Yeah, perfect. And when you're thinking about like the A to E and the history, what kind of things in the history will make you think actually this is more cardiac and vasovagal rather than a seizure?
Like the onset of it. So like if they fall and hit their face, that would be more like a loss of consciousness, cardiac, maybe kind of thing.
Okay.
Maybe they're OBS as well. So if their blood pressure's falling, or they're really, really tachycardic, or that you've got ECG changes.
Yeah.
Oh, and like an aura, like if someone said someone saw an aura. No, they described an aura before having the seizure.
Yeah.
Or if it's like jerking, tonic-clonic movements, that would be more epilepsy, right?
Yeah. Take that with a pinch of salt, 'cause sometimes you can have like slight writhing movements in like a vasovagal. But if it's a full-blown generalized tonic-clonic, doesn't last for like only a few seconds, then yeah, it's probably a seizure. So these are some of the like things that they could tell you in a question. So if it's really quick and they recover really quickly, they've probably had like a vasovagal episode, something more autonomic rather than a seizure. If they don't actually have like hypotonia and hypertonia, if there's a prodrome, so they've also got like some nausea and vomiting, feel a bit like sick, and then they faint, if they've got like other autonomic stuff, so if they're sweating, and then think about the circumstances they describe to you. So if it's someone who's like standing outside for a long time in a music festival or after a marathon, probably not a seizure, although always check their glucose, or if they've got known heart disease as well. And the opposite is also true. If you know they've got epilepsy and suddenly they're presenting in a seizure, they're probably having a seizure. And then this is the guideline or like the protocol for status. I've just lifted it from the NICE website. And I asked someone this in my sim yesterday, because we've got to do epilepsy for kids this year. And generally, it's fine in your like A to E to put this algorithm under A, because the thing that's like the consequence that you don't want from the seizure is to lose their airway. So when you do A, this like the lorazepam and following this protocol can be your treatment for A, and then you just do the rest of your B, C, D, E as normal. The thing that confused me the most in fourth year was the timings. So basically on here, what it says is if the seizure lasts for 5 minutes, then you give your first bit of benzodiazepine, be it lorazepam if you have IV access, buccal midazolam, or rectal diazepam. And then you wait 10 minutes. If it's still going, you give another dose. And then after that, you do the whole like phenytoin, calling an anaesthetist. And I used to get really confused when the question would be like, so this person's been seizing for 9 minutes and you arrive. And the general rule is if you're there at 5 minutes, give them the first dose. If you're not there at 5 minutes, give them the first dose as soon as you can, and then just keep to the same intervals. So in our question, we saw this person at 9 minutes. It's completely fine to give them their first dose of lorazepam at 9 minutes, as long as you review them 10 minutes later. Okay, does that make sense? I'm going to say it.
Yeah.
Yeah, okay, cool.
So it's asked how long they've been seizing for before you saw them. You just give the first dose and then
just as if they've been seizing for more than 5 minutes when you see them, doesn't really matter how far along they are, just give them the first dose as soon as possible. The important thing that you can take from it though is a bit of like in your head risk stratifying them. So the general idea with seizures are if they're lasting longer than 5 minutes, they're not going to stop by themselves, and you need some kind of like benzodiazepine strength to help them. If they last more than 10 minutes, they're probably strong, more than 15 minutes, sorry, they're probably strong enough to need 2 lots of the benzodiazepine. And the idea is like the longer they last, the stronger stuff you need. So if you're seeing this person and they've already been going for like 10, 15 minutes, in your head, you already know they're going to need at least 1-2 rounds of the benzodiazepine. So start thinking like, oh, they've been seizing for a while. Even if I haven't given them the 2 doses, I'm still going to call the anaesthetist earlier on. Does that make sense? I'm going to go with yes. Okay, fine. So this is the next part of the case. So Tom's had his seizure, it stopped. He's been transferred to the ward, and you notice that his shoulder is internally rotated and adducted. And when you ask him to, he says it hurts and he can't move it. So what's the most likely diagnosis that the X-ray is going to show?
Is it a posterior shoulder dislocation?
Yep, perfect. Okay, so shoulder dislocations, you don't need to know very much other than what I'm about to tell you. So crash course about shoulders. The most common type is your anterior one, and there's a bimodal age distribution. What are the 2 sort of age groups that it tends to affect?
Is one of them kind of teenagers, young adults?
Yep. And the other one?
Older people?
Exactly, yeah, old, frail, elderly people. And the reason why it happens in our age group is because we're all kind of really stupid and we like crash our cars and jump off fences and do tons of parkour, and basically trauma in our age group is more common. And sometimes if you have a fall on an outstretched hand, you can get a shoulder dislocation. And does anyone know why it when you have dislocated it, why it becomes externally rotated and abducted? Why does it sit in that position?
Is it like a muscle that pulls it that way?
Exactly, yeah. So if you go back to like fun second year times, all of like the muscles that mainly attach to your shoulder either come from your sort of scapula round the outside and attach to your greater tuberosity, or they come from your back and through the underside of your axilla and attached to the lesser one. So once you've dislocated it, those muscles act unopposed, and the sort of external ones will rotate it outwards, and the ones coming through your axilla will abduct it in. And for that reason, which nerve is high risk of injury?
The axillary nerve.
Exactly, yeah. And the like eponymous lesions that you could get is a Hill-Sachs or a Bankart fracture. I need to get this right. The Hill-Sachs is when your like labrum tears at the bottom, and your Bankart, which I have a photo of later, is where your humeral head has a depression fracture. Okay, so the inferior ones are really, really rare, like less than 1%, and the arm just looks like it's been pulled down. There's a funky Latin word for it, which I can't pronounce, and it's caused by hyperabduction. Anyone want to hazard a guess, like what could have caused that?
Is this the electrocution one?
Oh, I don't know about that. I've not heard of that, but it could be.
I think electrocution is the posterior one. Is a hyperabduction like hanging?
Yeah,
Something like that, like getting caught holding on to something.
could be, yeah. Most of the time it's sort of that similar action, but it's when like a child is like on a higher surface and a parent aggressively pulls them down and they're just hypermobile. So if a parent pulls them back and down, like off a fence aggressively, then it could cause an inferior one. And then the posterior ones are really often misdiagnosed because they're quite hard to see on an X-ray, and they happen due to uncontrolled muscle contraction, so probably seizures and electrocution. And you always, especially in the posterior one, need 2 views to check it. So I've got an X-ray here. Which kind do you think this is?
You're going to trick us now. You're going to be like, haha, you can't tell.
No.
Is it posterior because it's like the light bulb?
Not quite. So this is an anterior one. And if I show you in comparison, this is the posterior one with the light bulb. So when the light bulb sign is there, it's really prominent. And with the posterior one, can you see that like it's still at the level of the glenoid? It doesn't quite look like it's physically shifted down or up in any direction, whereas with the anterior one, it's like significantly below it. And this is what I meant by the Bankart and the Hill-Sachs. So sometimes you can have fractures of the labrum and the humeral head that accompany it as well. Okay, cool. So case 1 continued. So Tom's been referred to the orthopedics.
Wait, can I ask you for a bit?
Yeah, go for it.
You know, for that light bulb sign, what exactly is the light bulb?
So do you see, you can't see my pointer. Do you see like the humeral head?
Yeah.
Can you see if there's like an outline of it?
Yeah.
That looks like a light bulb, kind of.
Okay.
A weird light bulb.
Wait, Preena, if you go back to the other one for a second.
Yeah.
Just go back. Oh wait, I can't see. Oh wait. Go to the anterior one.
This is the anterior one.
Wait, why can I not see it? Okay, I can't see it now. Okay, can you see how on this one it's not really symmetrical? Like the left and the right side of the humeral head. Can you see that they're not really that symmetrical? You can say no. Yeah. Okay. Now go to the posterior dislocation. Now can you see that that's a bit more symmetrical?
Yeah.
That's basically the light bulb side, because the light bulb is symmetrical. That's the way I used to like basically recognize it. I think it's a fake news sign personally, because I can't see a light bulb either. But that's kind of what I use to differentiate between the two. Because in an anterior dislocation, you should see the medial side of the humerus. It should look like it fits cleanly into a socket. I think on a posterior one, you can't see the bit that cleanly fits into the socket because it's quite symmetrical. But yeah, I agree. I think it's a stupid sign.
Okay.
Got it.
So you referred him to the ortho reg, and the guy on the phone says to you, keep him nil by mouth. We're going to try and fit him in theatre, but if they can't reduce it, they'll take a if they can't do it on the ward, basically. So before we move on, that's basically shoulder dislocations management in one sentence. You try and reduce it with traction, counter-traction, and analgesia. If that doesn't work, theatre. So he says, could you please prescribe some maintenance fluid for him? And for the sake of this, we're going to assume he needs it for 24 hours. So here's his details again and his weight. This is going to take some time. It would be a solid sedation. So I'm going to give you guys 5 minutes to do it. And yeah, I will check back in half an hour. At past, not in half an hour.
By the way, you do not need to know how to reduce the shoulder exactly. Like, you do not need to know the movements, in case anyone thought that was coming up.
Okay, 1 more minute. Okay, let's go through it. So on a scale of like 1 to 10 in the chat, can you guys put how confident you were at this? Because I've broken it down over quite a few slides. So I just want to go at the right pace. So if you feel like had no idea where to start, put like around 1, and then if you feel like you could do it, put around 10, and just put a number in the chat. Otherwise, I'll just go through it all. Okay, I'm just going to go through it all. Okay, fine. So maintenance fluids. You basically give someone maintenance fluids if they are nil by mouth, because you don't want them to have no electrolytes, you don't want them to become dehydrated, and you don't want them to become hypoglycemic. So the way you do it is you get their weight and you follow this guideline, which is basically just nice. I would say learn this, but it would also be harsh if they didn't prompt you and give this to you in a station. It's also on the BNF, so don't worry. So this basically says what you need to give someone based on their weight for the whole day. So you need 20 to 30 mils per kilo of water, 1 millimole of like sodium, potassium, and chloride, and 50 to 100 grams of glucose. So the first part in maintenance fluid prescribing is basically just work out how much you need for his weight. So I worked out like this. I just times everything by 80 that needed to be times by 80, and I got these numbers. And then the next thing you want to do is pick the nice numbers, basically. So I went with the 2 liters for the water and stuck to the 80 because that's fine. And glucose, I'm going to keep at 50 to 100 because they're both also quite nice. Okay, any questions before I move on? Okay, fine. So the next thing with maintenance fluids is you need to work out what's limiting you. And most of the time it will be your potassium. So what's the rule with how much potassium you can give someone peripherally? What's the max you can give, or the fastest? Okay. So the fastest is you can only give 10 millimoles an hour, and in a litre bag, the max you can give is 40 millimoles. That I would learn off the top of my head. Does anyone know when the only time you can break this rule is?
Is it if you have central access and you're in ITU?
Yes, or
Severely hypokalemic.
Maybe, I don't know. The one I was thinking of is in DKA. In DKA, when you add it to the second bag, you're going to go at a faster rate than this, and that's fine. Okay, fine. So then you're going to pick your fluids. So what are the main options that you've got for fluids? What are the big ones that we know about?
Sodium chloride.
Yeah.
Or Hartmann's.
Yeah. And the third one?
Dextrose.
Perfect. Yeah. So these are our 3. So we know that sodium chloride has literally only that in it, sodium and chloride. Hartmann's has some potassium in it already, which is important to keep in mind. And then the dextrose only has glucose in it. So in our final prescription, you're going to need in total 2 liters of stuff. Some of that has to be dextrose, some of that has to be sodium chloride and Hartmann's. And then it's just kind of a numbers game. I'd say roughly learn this table. Don't go like too crazy with it, but don't learn the human plasma bit. That's not important. Learn what's in the 3 fluids. And this table is per liter. And then once you've got that down, basically you just need to sort of like figure out what goes in each bag and how much of each bag you want to give. And the way I do it is I prioritize with the right spelling, sorry, the sodium chloride first, and then however much else water I need to make up, the rest of that becomes dextrose. And then you can add the potassium into any bag. So that's the last thing I do. So if we start with the sodium and the chloride, I need to give roughly 80 millimoles. And yeah, I could use half a bag of Hartmann's, but it's probably more accurate to use half a bag of sodium chloride, and then you're at 77 of each, and that's good enough. So I'm going to do that. I'm going to use half a bag of sodium chloride. And then I've still got to make up 2 liters. So I was like, right, well, the rest of it is 1.5 liters of dextrose. And usually you always just double check, am I giving too much glucose? Not really. Like if your range is 50 to 100, 1.5 bags is like 45 to 75, you're fine. And then you're like, great, okay, so somewhere into that, I need to add 80 millimoles of potassium. And there's no hard and fast way to split it. And this is why with prescribing, you just need to tell yourself, as long as it is within the rules, it's fine. Everyone might do it slightly different ways, and the mark scheme will always allow for that. But however way you do it, just make sure you don't give more than 40 millimoles in one bag, and more than 10 per hour. So either adjust the bags you give it in or the rates that you give it in. Okay, so that's what I did in the end. I put 40 in one bag, 40 in the other, and then I just adjusted the rates, and this was my final prescription. The only thing I'd say is this black arrow is me being lazy, but you should ideally give the sodium chloride first, because if you give someone 1.5 liters of fluid and it doesn't have any sodium in it, you're going to make them, you're going to dilute them and make them hyponatremic. So try and give the sodium chloride first. Does that make sense?
Can I just ask a question about the potassium?
Yep.
So when we had a thing on a really bad tutorial on fluid prescribing, but we were told that you're no longer allowed to add or you shouldn't add potassium to bags of fluid anymore because you make mistakes. So are there kind of, you know how you can get pre-mixed potassium? Would you do that instead?
Yeah, so some preparations will have it pre-mixed. The other thing you can use is like a 0.18 sodium chloride bag with other stuff in it. Sometimes some hospitals stock that, but you can also use Hartmann's. And to be honest, in real life, they will have they're never going to be kept nil by mouth for 24 hours. So what you can do is just make sure that the first few bags that are tying them over till their operation has the potassium in it. Does that make sense?
Yeah, that makes sense.
Yeah. The other thing is, so in the other tutorials I've done, we've done resus fluids. This is us doing maintenance fluids. The last one is redistribution and fluids after you've lost some. And what I'd say with that is there's a really good Geeky Medics case. I literally worked through it last night when I made this for you guys. And just have a go doing everything in that case and then reveal the answers. And it will just help you get to grips with the redistribution fluids as well. Okay, fine.
Wait, sorry, can I just ask a quick question?
Yeah.
Back about the fluid. So the duration, does it
Yeah.
matter? So it was over 24 hours. Could you have done 8 hours?
Oh yeah,
all
absolutely.
Okay.
Yeah.
In real life, don't do that. But in an exam, that's fine.
Okay.
Because you do not want to be running fluids through someone overnight. Generally, is a good rule, because it's a bit inconvenient. But yeah, in an exam, it's fine. Also, just the other thing, in exams, add potassium chloride to your bags because that's what they expect you to do. In real life, again, you use the pre-mixed things, but in an exam when you're prescribing your infusions, do it this way.
And in real life, try not to have all of them going at different rates because it's kind of a pain for the nurses to change it. So stick to one rate and adjust the time or duration accordingly. Okay, fine. Case 2. So this is a new person. He's 15 years old. He's got purpuric rash that's non-blanching. He's also had some, I need to check my grammar before I make these, but he's also had some diarrhea and vomiting. And when you speak to him, you realize he's really jaundiced, just generally unwell. And he tells you that he's grown up in lots of different countries. So he's not sure of his vaccine record. What's the most likely causative organism for his presentation? Okay, any guesses?
E. coli?
Yep, who said that? Sorry. Oh, okay.
Me.
Yes, okay. Yeah, can you talk me through why? What are you thinking?
I can't remember what the toxin is called, but there's
Mhm.
like a toxin, and then I think, is this hemolytic uremic syndrome?
Yeah, exactly. So the first thing to note is that it was a purpuric non-blanching rash. So a non-blanching rash is basically when there's bleeding in the skin. And the one that like is a buzzword for sometimes is petechiae, but don't get it mixed up with purpura. So petechiae is when it's like the really small vessels and it's like discrete dots. The purpuric one is when like it's kind of just sort of red in a large patch. The petechiae is like meningococcal septicemia, endocarditis, or ITP. Whereas the purpura, you've got to think a bit more heme. So it could be HSP, DIC, all of this stuff that we're going to talk about in a second. Just a quick note on meningococcal septicemia. I'm not going to like do meningitis today, but what's the difference between meningitis and meningococcal septicemia?
So is it that the meningitis is the inflammation of the meninges, so it could be due to a number of different bacteria, viruses, fungi, could be aseptic as well, but meningococcal septicemia is referring specifically to like the meningococcus in the blood.
Yeah, exactly. And there you can have either meningitis due to all of these things that Neeraj said, and also due to just meningococcal, or you can have meningococcal septicemia, which is just like an ill individual with meningococcus in his blood. That's what causes the rash. And you can also have both of them together. So you can have someone who's septic and has meningitis. But just try and distinguish it in your mind. And there's a really good, nice guideline table for it as well, because the rash is indicating that he's septic. The photophobia, all of that kind of stuff is indicating that he has meningitis, but they don't necessarily have to have both for it to be meningococcal disease. Okay, so in this question, he had a purpuric rash, he was jaundiced and he was unwell, and he didn't have, like, they didn't know about his vaccines. So generally, with Neisseria and Listeria, he's a bit too old. That's more like under 2 years old. With the strep and the meningococcus, because he hasn't had his vaccine, it could be, but again, I haven't told you that he's got a stiff neck or photophobia, and there's no focal neurology, nothing to suggest that he actually does have meningitis. In fact, what he does have is HUS caused by the E. coli, which is probably what's caused his diarrhea and vomiting as well. Okay, so hemolytic anemia. I figured I'd do this for you guys because you guys are asking for a lot of heme, and it's like where do I start? So what's the two main ways you can categorize it? How do you approach it?
Is this intravascular, extravascular?
Yeah, that's a good one. Is there another way that you know of?
The inherited and acquired.
Yeah, exactly. So it can be inherited, it can be acquired, and if it's inherited, I'd say learn the inheritance pattern very basically, like autosomal dominant or recessive or X-linked. Don't bother with like the expression and penetrance and all of that. Just very basic inheritance pattern. And basically, these ones are just anything to do with the red blood cells. So if it affects the enzymes in it, the membrane, or the physical hemoglobin, and these are the main conditions.
Do you guys know the cheat way of figuring out if it's autosomal dominant or if it's a recessive thing? If you can't remember, there's a rule that applies for like 80% of conditions. 80% of genetic conditions, you can figure out if they're dominant or recessive. No? Okay, basically, if it's like a structural problem or a structural protein, that's the issue, then it's likely dominant. If it's an enzyme, it's likely recessive, but that doesn't mean necessarily autosomal. It could also be X-linked or something, but dominant or recessive, you can, if you forget, just fall back on that because it works 80% of the time.
Okay, so with the acquired ones, what are the ways that you could classify it?
Immune and autoimmune, and autoimmune and non-autoimmune.
Yeah, exactly. So is it immune mediated and is it not immune mediated? So if it's immune mediated, it could be autoimmune or alloimmune. And autoimmune is very broadly like a warm or cold hemolytic anemia, or the alloimmune are just transfusion reactions, essentially. The non-immune ones are just kind of like, in my head, the ones that don't really fit. So your microangiopathic microangiopathic hemolytic anemias, which is your MAHA, M-A-H-A, the mechanical ones, which are like a heart valve that's shearing all your red blood cells and causing them to hemolyze as it pumps, malaria for infection, and then miscellaneous ones, which I put in the notes for this presentation, but like minimal effort on that, guys. And then generally, what I would say is as you approach hemolytic anemias, think about them in this classification and then think like, are they intravascular or extravascular? And if they're intravascular, the red blood cells are literally breaking in the vessels. So you're going to have free hemoglobin and you're going to have hemoglobinuria and you're going to have all the like pre-hepatic jaundice, the dark urine. If you're extravascular, it will be more like splenic hypertrophy, sometimes portal hypertension if it becomes that big. And then next to all of these, to sort of guide you guys, I put stars. So basically, the more stars, the more I'd spend learning about them. So for example, with sickle cell thalassemia, I'd like learn the genetic, learn how it presents, how you manage it, what do you do with a crisis. With the like 2 stars, I'd learn like how it presents, roughly what you do. And then with the 1 star, just like very simple, like what am I going to see on a blood film? Why is this happening? Buzzwords for it, basically. Okay, so I'm going to quickly talk about the microangiopathic hemolytic anemias, which is what our case had. And there's 3 of them. There's HUS, TTP, and DIC. I've put ITP in this table as well, just because it's kind of similar, but it is not a hemolytic anemia. Yeah, it's not a hemolytic anemia. So ITP, does anyone know what causes it? PS, I'm really sorry, but we're going to run like 10-15 minutes over.
Is it antibodies to platelets?
Exactly. So you have an infection, or your autoimmune system is just running out of control, and you form antibodies against this glycoprotein on your platelets. You have low platelets, which is the thrombocytopenia, and you bleed. It's quite self-limiting in children, but in adults, you need to give them steroids, and if they're actively bleeding, you need to give them IVIG. It's not an anemia. Everything else in their clotting is normal, okay? So try not to let that get in the way when you read those questions about hemolytic anemia. Okay, so the first one is HUS, which is what our patient had. Do you guys know what causes it? I think Esme said it already. So it's the E. coli, and there's a specific strain, and this strain produces a toxin. And the way I remember hemolytic uremic syndrome is just by its name. So hemolytic, you get hemolysis and anemia, and that causes your high bilirubin, your dark urine, and your uremia means that like you have a really high uremia, and then you get basically bleeding because of low platelets on your legs and your buttocks and back sometimes. And basically, they don't really know how, but the toxin kind of causes damage to your endothelial cells. And then that causes your red blood cells to shear because it's not so nice and smooth. And that's why you also get some schistocytes on a film. and you just treat it the same way. So you give steroids, FFP, plasma exchange if you need to. The FFP replaces basically your platelets and clotting factors and things like that. TTP is basically HUS, but with a very different mechanism. Does anyone know what the like buzzword protein is in TTP? No? Okay. So in TTP, the important protein is called ADAMS 13. And basically what this does, you can have a congenital deficiency to it, and then all it takes is a trigger, or it can be an autoimmune destruction. But what this enzyme does is you have your like von Willebrand factor, and when it's produced, it's formed in like large chunks, and then this protein cleaves it to get your like small, nice little von Willebrand factor. And then when you need to clot, all of those like little factors will come together and make that large chunk again. If you don't have this enzyme, then you just are stuck with that large chunk, and you end up getting microthrombi going to the brain, and that's what causes your neurological symptoms in TTP. So basically, you get everything that you get in HUS, but also fever and some neurological symptoms. And that will be the thing that gives it away in an SBA, which one is which, whether they've got some like focal neurology or a fever. Okay, and then the last one is DIC. And the way I think about DIC is basically if you have anything that throws your body into like such stress that it doesn't know whether it's procoagulant or anticoagulant, the balance is just off. And then in some places you're going to bleed and bruise, and in other places you're going to clot. And it just becomes a toxic cycle, because the more you bleed, the more your clotting factors get used up, and then the more you're likely to bleed elsewhere. And you just have no control of correcting it. And if you have like a predominant presentation, so if you're like very clotty, you can give like unfractionated heparin, or if you're very like a bleedy individual, you can give some platelets and FFP. But often people are like a bit of both, and it's a really poor prognosis because you just don't know how to manage them. So that's DIC. Any questions about this like mega slide before I move on?
Quick question on
Mm-hmm.
the HUS.
Mm-hmm.
Did you say that there are low platelets for HUS as well?
Yeah, because you get the purpuric rash from it.
Is there a reason for the low platelets?
I don't think I know the reason.
All of these situations cause low platelets. They cause unregulated activation of the clotting cascade, which consumes platelets. The reason you do not give platelets is because if you give them, just more of them will be used up. It doesn't really achieve anything. Yeah. The only question I have for you guys is, do you know what any microangiopathic hemolytic anemia? So not ITP, the other three things. Do you know what finding you would get on blood films? Because this is something that comes up. Oh wait, you've already said it.
I've said it.
Never
Sorry.
mind. Yeah. Do you know what one other thing causes schistocytes on a blood film?
Metal heart valve.
Metal heart valves, because they share it. And yeah, so a common question is someone's recently had a heart like valve operation and they're suddenly anemic. Oh, I wonder what's going on. No, you just keep that in mind.
Okay, so we've got two more really short cases. So this is the next one. Billy mentions to you that he's got some. Oh no, this is continuing. Billy, he mentions that he's had the diarrhea and vomiting quite regularly, so his threshold to go and get help is quite low. Should be high. He regularly has fuel and exercises, but still struggling to gain weight, and you're awaiting a gastroenterology referral for him. He says that his GP sent off some test, but he doesn't know what it is, just that it was really good at ruling out IBD, which is why his GP did it. Which test and why was it ordered?
I think it's the calprotectin, but I don't know which
way.
Yeah.
Okay. Anyone want to help?
is it the calprotectin because it's highly sensitive?
Yep. Yeah. So this is the bit of CPP that's going to come up every year, and I'm just going to bring it forward to you guys now. Remember this table here. So the sensitive is like of everyone who has it, how many positives, and the specific is of everyone who doesn't have it, how many negatives. And your main differential with Billy here should be IBS or IBD, and the first test you do is the fecal calprotectin. What do you use a fecal calt blood test for?
Colorectal cancer.
Perfect, good, yeah. And the H. pylori breath test is for H. pylori. Okay, so IBS, what kind of things in history would make you think this person has IBS? P.S. It's a great differential because anything, literally anything gastro could be IBS.
If they don't get woken up by diarrhea, I guess.
Mm-hmm. Yep.
If their symptoms are relieved by like defecating.
Yep. Anything else?
If their symptoms kind of follow kind of emotional stresses in their life.
Yeah, very good. Okay, so we have the ABC for 6 months, which is abdo pain, relieved by defecation, bloating, and change in bowel habits. And then there's, basically any gastro symptom that could be associated with those. But the risk factors that you want to think of is, are they sort of young, stressful lives? They have triggers for it. They've got maybe some history of like physical and sexual abuse, because that will make you think more likely to be IBS. And IBS is really generic and it's really difficult to actually diagnose. So I think the best way that they could test us about it actually is going the other way, which is, what are the red flags you cannot miss? So what are the 2 big cancers? If anyone has these symptoms, you've got to keep in the back of your head.
Maybe colorectal cancer.
Yep. And what's the other one? If I told you it was sadly one of the like 5th year topics that you might need to know in 4th year. Very briefly. So I'd say ovarian cancer in women. So ovarian cancer, you do a CA-125 if they're over 50 and they've got like persistent bloating, loss of appetite, the pain's cyclical, and generally if you're over 50 and you have new IBS, that's not IBS. People over 50 don't get IBS, and if they've got a pelvic mass or an abdominal mass. And then colorectal cancer. So what are the red flags for colorectal cancer?
Like iron deficiency anemia.
Yeah.
PR bleeding.
Yeah.
Like the constitutional symptoms like weight loss.
Yeah. Perfect. And think about your like night sweats and fevers in pretty much anyone as well. Okay, fine. Last case. No, I don't even know what we are. Yeah, last case. So 2 more cases. Sorry.
Wait, a quick thing. If you're going to learn one history really, really well for exams, it is colorectal cancer. It was a 10-minute station in my year 4 OSCE, and it came up this year today in finals. Like, it's like the commonest single history that comes up. So like, learn it really well.
Okay, so Jenny is a 67-year-old hairdresser. She comes to ED. She's had some small amount of blood in her vomiting. She's currently got some epigastric pain, and it's she's had some pain for the past few weeks. It tends to be relieved by eating, and I've shown you her hands in the photo. Which complication is she most at risk from?
Upper GI bleed.
Yep. What's her diagnosis?
It's one of the ulcers. I think, is this the gastric one?
Okay.
I don't know if it's duodenal.
Okay. So you're exactly right. She is. She's got an ulcer of some kind, and the risk is that it goes through the wall and causes bleeding through an artery. And the clues that I gave you for it is that she's a hairdresser. And then I've shown you her hands. So think like rheumatoid arthritis, osteoarthritis. And the reason why I didn't give you like frankly overt rheumatoid arthritis is because that's not really common anymore with biologics. But you will still see people with like really subtle signs on their DIP, on their PIPs and MCPs. So yeah, she has some rheumatoid arthritis, and I wanted you to make the link that she takes regular NSAIDs. And on top of that, she's had some generalized abdominal pain that sounds like it's a peptic ulcer. So you're worried whether she's got an upper GI bleed. The surgical emphysema and the esophageal rupture would be a good shout if you thought it was a Mallory-Weiss tear, but it wouldn't explain her long-standing pain. SVT, important, because epigastric pain could be an MI. And then pancreatitis, yeah, because she's got colicky pain, and maybe that's a gallstone progressing. But I've given you her hands, and that doesn't fit anywhere with that. Okay, so this is a crash course peptic ulcer disease. There's two types. There's a gastric and a duodenal one. And the way I remember it is if there's acid on the ulcer, it becomes irritated. So with the gastric ones, when you eat, the acid is produced to digest the food, and that's why it irritates the ones in the stomach. So in the gastric ones, the pain is worse when you eat. Whereas when you eat, your pyloric sphincter shuts and nothing passes through your duodenum. So actually in your duodenal ones, that gets better by eating. And when you start fasting or digesting, your pain is worse. And for either of them, the most common cause is like H. pylori, NSAIDs, corticosteroids. And the way you diagnose it is with an OGD. Sometimes you do a biopsy. And the main complication you need to just watch out for is that they don't cause perforation or hemorrhage. And the important artery, anyone know? It's quite obvious.
Gastric?
Close. It's the gastroduodenal one. Because that runs sort of like behind the duodenum to get to the greater curvature of the stomach. Okay, final one, I promise. So you're asked to review this ECG of a 35-year-old in ED. He's currently hemodynamically stable. What's the most important aspect of your management that you need to do in a timely manner? Any guesses?
Amiodarone.
Okay, yeah, good. Tell me about this ECG. What can you see?
Preena, just check the chat as well, by the way.
Oh, I can't see anything in the chat.
Oh, it might have just broken for you. We'll talk about why it's not vagal maneuvers, and we'll talk about when you use magnesium in a minute.
Okay, fine. Okay, cool. So the answer was amiodarone. I can't see the chat, so someone say what they think the rhythm is.
Is it VT?
Mm-hmm.
Because it's a broad complex tachycardia, so it's not supraventricular. Or it could be supraventricular if they had other problems, but...
Thank you.
Yeah.
I'm so proud. Okay, exactly. So when you look at this ECG, if I run you through the interpretation, so you always do rate, rhythm, axis, and then have a closer look. So rate, it's like 2 boxes between each QRS complex. So it's like 150, 160 beats per minute. This is definitely some form of tachycardia. Rhythm, it's kind of every 2 boxes. So this is roughly regular. Axis looks kind of normal. Okay, and then if you sort of like just glare at it, the thing that stands out to you most is that you've got a wide QRS. And therefore, this is a broad complex tachycardia. And that means that where the electrical activity is coming from the ventricles, because it's not nice and coordinated through the Purkinje fibers. It also could very well be like a supraventricular tachycardia with a bundle branch block, and because you've got that bundle branch block, it sort of like widens your QRS. Does that make sense? I'm going to go with yes. So that's what it means by aberrancy, which is SVC plus aberrancy, which is anything that could cause the like widening of the QRS, so left or right bundle branch block, partial fascicular block, etc., etc. So if I take you through the management generally, I have just taken these out of the handbook, and this is what I learnt last year, and it got me through. So if you have a VT or a VF, if you have a genuine broad complex tachycardia, someone's mic is on, it's kind of annoying. Thank you. Okay, so if you have a genuine broad complex tachycardia, of which there's only VF and VT, then you need to follow this pathway. And basically what it says is if they're hemodynamically unstable, shock them. If they're not hemodynamically unstable, give them some amiodarone and start to find out what's causing it and treat that. So that's your broad complex tachycardia. If you have a narrow complex tachycardia, so if you have like SVT, AF, etc., etc., this is the management. And basically it's very similar. So it's if they're hemodynamically unstable, shock them. If they're stable, think about like vagal maneuvers and then adenosine. So basically, in fourth year, I was a bit like, okay, these two things are separate in my head. And what do you do if you don't know whether this person actually has SVT plus a bundle branch block, or like, what do you do if you don't know that's the case? And in that case, there'll be things in the history which guide you. So if in the history they tell you they've got AF, or they tell you they've got Wolff Parkinson White, if they tell you something that makes it more likely to be an SVT plus a bundle branch block, then you'll know that that's what it is. The other thing is, and I asked a cardio reg this, which is what he said was, it doesn't matter if someone has VT or VF and you give them adenosine or you give them a vagal maneuver. The only thing that it's doing is delaying them getting the correct treatment. So you giving adenosine isn't going to make their VT or VF worse. It's just going to delay the time it takes for them to get their amiodarone, which is why if you're ever in doubt, treat it as if it's VT and stop them going into VF. Question, go.
Yeah, just with if it was an SVT but they had like a bundle branch block, or they had like Parkinson White, is this the one where if you actually gave them adenosine, then that wouldn't be good because you would cause like all of the signals to go past the AV node through the accessory pathway?
So
there was one that I read about. I don't know. I did cardio in September, so I can't quite remember.
Sorry, what was that, Niraj? It just rang a bell. Just say it again, because it just rang a bell in my head.
Something about not giving adenosine in SVT with aberrant conduction, because I think it's with that.
So there's like a specific subtype, I think, of Wolff Parkinson White, where you can't give adenosine because basically it'll increase conduction down the aberrant pathway. You're right. That's super niche. I'll try and find out which one exactly it is. That's not going to come up, but that is very good to know in IRL. But yeah, it's unlikely to come up. There is a specific use case where you don't use it though. But otherwise, use this algorithm. For example, just use this algorithm. Yeah. I'll post on the group when I figure out what it is.
And if you're ever in doubt, just treat it as VT, because that's the most dangerous one currently. Okay, So just to go back a slide, for the people who are thinking like magnesium, you use magnesium for torsades, and torsades has a really distinct appearance. Does anyone know what that looks like?
Yeah, wait, can I just ask something? Because basically, I said magnesium because I know it's for polymorphic, but like torsades, obviously, because that looks like the Arctic Monkeys album cover, and this doesn't look like that. But then I was looking at all the waves, and they don't all look the same. So I thought then it's polymorphic, but then am I just thinking of polymorphic in the wrong way?
No, so I do see what you mean, but when you have polymorphic in torsades, the way I think about it is there's like polymorphism in every aspect of the QRS. So in like the upstroke and the downstroke and the overall size of it all, and it has this like sinusoidal variation. So like it will be small and then big and then small and then big, not on every single one, but enough on a trace for you to spot it. Whereas with this one, all of the like, I know it varies ever so slightly, maybe like by 1 or 2 boxes, but most of the QRSs are pretty much the same height in each lead.
Okay, so it's not to do with like, because there's like little M's and some of them don't have M's.
Yeah, but
to do with, like height of QRS complexes.
Yeah, the other way that tends to do it for me is looking at like a lead by itself. So like pretty much every single one in lead AVF has an M, and like pretty much all the ones in V1 look the same. In torsades, every single QRS will be ever so slightly different.
Okay, got it. Yeah, thank you.
Cool. Okay, that was the last case. So if you have any questions, I'll hang around for a bit and chat. I'm really sorry it ran over. I've never done one by myself, so I was like, I don't know how much to shove in one go. I'm gonna put the feedback link in the chat.
I can do it if you want.
But I haven't been able to see the chat this whole time, so if you haven't seen my message, I'm not surprised.
Yeah, no, they can see it. Any questions, concerns?